Hi everyone, this is the presentation for schizophrenia spectrum and other psychotic disorders. There is a lot of information in this PowerPoint, so definitely bear with me as I'm going through it, and we will talk about everything in class. So schizophrenia is a chronic and severe mental disorder that affects how a person thinks, feels, and behaves. People with schizophrenia may seem like they have lost touch with reality. Although schizophrenia is not as common as other mental disorders, the symptoms can be very disabling. Approximately 7 or 8 individuals out of 1,000 will have schizophrenia in their lifetime. People with the disorder may hear voices or see things that aren't there. They may believe other people are reading their minds, controlling their thoughts, or plotting to harm them. This can be scary and upsetting to people with the illness and make them withdraw or extremely agitated. It can also be scary and upsetting to the people around them. People with schizophrenia may sometimes talk about strange or unusual ideas, which can make it difficult to carry on a conversation. They may sit for hours without moving or talking. Sometimes people with schizophrenia seem perfectly fine until they talk about what they are really thinking. Families and society are impacted by schizophrenia too. Many people with schizophrenia have difficulty holding a job or caring for themselves, so they may rely on others for help. Stigmatizing attitudes and beliefs about schizophrenia are common and sometimes interfere with people's willingness to talk about and get treatment for the disorder. People with schizophrenia may cope with symptoms throughout their lives, but treatment helps many to recover and pursue their life goals. Researchers are developing more effective treatments and using new research tools to understand the causes of schizophrenia. In the years to come, this work may help prevent and better treat the illness. So, symptoms of schizophrenia usually start between the ages of 16 and 30, and in rare cases, children can have schizophrenia too. And we are going to talk about that when we talk about prevalence. But the first thing that I wanted to talk to you about are the different symptoms of schizophrenia. And the first class of symptoms we're going to talk about are referred to as positive symptoms. So, positive symptoms are psychotic behaviors not generally seen in healthy people. People with positive symptoms may lose touch with some aspect of reality. So these symptoms include hallucinations, delusions, thought disorders, and movement disorders. And we are going to go into depth into each one of these. So the first of the positive symptoms that we are going to talk about are delusions. And we talked about delusions back when we spoke about bipolar disorder as well. So these should sound kind of familiar to you. So just to refresh, delusions are strongly held beliefs that are not consistent with the person's culture. Really, really important to take into consideration your client's culture in thinking about the things that they present with or the things that they are talking about is normal to them within that culture or not. Delusions persist even when there's evidence that the beliefs are not true or logical. People with schizophrenia can have delusions that seem bizarre, such as believing that the neighbors can control their behaviors with magnetic waves. So if you look to the bottom of this slide, they talk about bizarre delusions. So those are clearly implausible and not understandable to same culture peers and do not derive from ordinary life experiences. They express a loss of control over their mind or body. So definitely believing that the neighbors could control your behavior with the magnetic waves would be a bizarre delusion. They may also believe that people on television are directing special messages to them, or that radio stations are broadcasting their thoughts aloud to others. So these are called delusions of reference. So these referential delusions, the second bullet on the list. Sometimes they believe that there's someone else, such as a famous historical figure. They may have paranoid delusions and believe that others are trying to harm them, such as by cheating, harassing, poisoning, spying on, or plotting against them, or the people they care about. So those are called persecutory delusions. That's the first one on the list. The grandiose delusions is that believing there's someone else, is a famous historical figure, or that you have exceptional abilities, that you're like a superhero, or that sometimes you can see people with schizophrenia think that they are Jesus or they're God or God is talking to them. So that's another example of a delusion. When an individual believes falsely that another person is in love with him or her, or the conviction that a major catastrophe will occur, and then the somatic delusions, so the preoccupations regarding health and organ function. The next positive symptom we're going to talk about is hallucinations. So hallucinations are sensory experiences that occur in the absence of a stimulus. They can occur in any of the five senses, so vision, hearing, smell, taste, or touch. With schizophrenia, voices or auditory hallucinations are the most common type of hallucination. Many people with the disorder hear voices. The voices can either be internal, seeming to come from within one's own mind, or they can be external, in which case they can seem to be as real as another person speaking. The voices may talk to the person about his or her behavior, command the person to do things, or warn the person of danger. Sometimes the voices talk to each other, and sometimes people with schizophrenia talk to the voices that they hear. People with schizophrenia also may hear voices for a long time before family and friends notice the problem. Other types of hallucinations include seeing people or objects that are not there, smelling odors that no one else detects, and feeling things like invisible fingers touching their bodies when no one is near. The thing to remember about hallucinations when a client is talking to you about these kinds of things, they most likely occur in the context of a clear sensorium. That's what it says on the bottom bullet. So not while falling asleep or waking up. So sometimes there's that period where you put your head down on the pillow and you're not quite awake and you're not quite asleep. And you hear things or you see things, you're kind of dreaming, you're kind of not dreaming. Things that happen during that time would not be considered a hallucination. That would be within the realm of normal. So some key features, another key feature of positive symptoms can be around a person's thought. So a thought disorder is an unusual or dysfunctional way of thinking, and one form of this is called disorganized thinking, which is the top bullet on your slide. So disorganized thinking is inferred from an individual's speech. So thinking back to bipolar disorder when we talked about pressured speech, disorganized thinking in schizophrenia would also be inferred from an individual's speech, but it would look a little different. So it would look like topic switches, which we would refer to as derailment or loose association. So kind of the person is talking and you can tell that their thoughts are just kind of all over the place. Answers to questions are obliquely related or completely unrelated. So this is when they're called tangential. That's on a mental status exam. You'll see that word. Let's see. When a person has trouble organizing his or her thoughts or connecting them logically. Also, he or she may talk in a garbled way that is hard to understand. So that's often called word salad. In some, I know on the mental status exams for Strong and for Rochester General Health, for the hospital, that tangential or word salad or incomprehensive, those are actually check boxes that you can check off when you do a mental status exam. So knowing what that language means is important. Another form is called thought blocking. This is when a person stops speaking abruptly in the middle of a thought. And when asked why he or she stopped talking, the person may say that it felt as if the thought had been taken out of his or her head by someone or something. Or a person with a thought disorder might make up meaningless words. So they're talking and they're just saying words that don't mean anything. Symptoms must be severe enough to impair effective communication. So the person's not able to talk with somebody else, or the person does talk with somebody else and that other person doesn't understand what they're saying. Movement disorders are also a key positive symptom with schizophrenia, so they may appear as agitated body movements. A person with a movement disorder may repeat certain motions over and over again. And on the other extreme, a person may become catatonic. I'm going to show you lots of examples of all of this, but catatonic behavior I think is pretty fascinating. It's a state in which a person does not move and does not respond to others. It's very rare, but it was more common when treatment for schizophrenia was not available. But it does happen. So, you can actually see by a person's posture, how a person is standing, what they're doing with their face, so this like staring or grimacing or even the echoing of somebody else's speech. It talks about catatonic excitement, so excessive motor activity without any cause of it, or this complete lack of verbal or motor response to something. And this rigid, inappropriate, or bizarre posture is a positive symptom of schizophrenia. So like I said, we will definitely look at lots of examples of those so we know what we're looking at. So in schizophrenia, you can also have negative symptoms. Negative symptoms are associated with disruptions to normal emotions and behaviors. These symptoms are harder to recognize as part of the disorder and can be mistaken for depression or other conditions. And they include the following. So diminished emotional expression, reductions in the expression of emotions in the face, eye contact, intonation of speech, movements of the hand, head, and face that normally give an emotional emphasis to speech. Avolition, so decrease in motivated, self-initiated, purposeful activities. Alogia, diminished speech output. Anhedonia, if you remember from depression, so lack of pleasure in things that you used to find pleasurable. And asociality, the apparent lack of interest in social interactions, and may be associated with avolition, so may be associated with this decrease in motivation, but it can also be a manifestation of limited opportunities for social interactions. So for an individual presenting with symptoms of schizophrenia, they might be withdrawn from social situations because of the schizophrenia. So we're really talking about things like flat affect. When we say a client has flat affect, that's that diminished emotional expression, difficulty beginning and sustaining activities, this reduced speaking. People with negative symptoms may need help with everyday tasks. They may neglect basic personal hygiene. And sometimes that may make them seem lazy or unwilling to help themselves. But the problem, it's really important to remember, these problems are symptoms caused by the schizophrenia. It's not because the person is lazy, and it's not because the person doesn't want help with things. It's really caused by the schizophrenia. One other aspect I wanted to talk about are cognitive symptoms. So for some clients, the cognitive symptoms of schizophrenia are subtle, but for others, they are more severe, and patients may notice changes in their memory or other aspects of their thinking. Similar to negative symptoms, cognitive symptoms may be difficult to recognize as part of the disorder. Often they are detected only when specific tests are performed. Cognitive symptoms include the following. So poor executive functioning, which as you know is the ability to understand information and to use it to make decisions. Trouble focusing or paying attention, and problems with working memory, so the ability to use information immediately after learning it. Poor cognition is related to worse employment and social outcomes and can be distressing to individuals with schizophrenia. So lots of symptoms, a very, very impairing kind of illness. So let's jump into the DSM5 diagnostic criteria for schizophrenia. Criterion A, 2 or more of the following, each present for a significant portion of time during a 1-month period or less if successfully treated. So at least one of these must be number 1, number 2, or number 3. So one of them must be delusions or hallucinations or disorganized speech. Also that grossly disorganized or catatonic behavior and negative symptoms as well. So for a significant portion of the time since the onset of the disturbance, the level of functioning in one or more areas such as work, interpersonal relations, or self-care is markedly below the level achieved prior to the onset. Or when the onset is in childhood or adolescence, there's a failure to achieve expected level of interpersonal, academic, or occupational functioning. There's a continuous signs of the disturbance persistent for at least 6 months. So there's your duration. Schizoaffective disorder, which we're going to talk about in a little bit, and depressive or bipolar disorder with psychotic features have been already ruled out, either because 1, there was no major depressive or manic episode, or 2, if the mood episodes have occurred during the active phase of symptoms, they've been present for a minority of the total disturbance of the active and residual periods of the illness. Again, not attributable to the psychological effects of a substance or another medical condition, just like every other diagnosis that we've looked at so far. And if there's a history of autism, spectrum disorder, or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are also present for at least 1 month. So if you remember, schizophrenia has that disorganized thinking, that language piece through speech. So you want to make sure that if there is a communication problem or a language problem, you have delusions and hallucinations as well in order to make the diagnosis of schizophrenia. And then here are the specifiers. You use these only after a 1-year duration of the disorder and if they are not in contradiction to the diagnostic course criteria. So first episode, currently in the acute episode. So this is the first time the disorder has manifested, meeting the defining diagnostic symptom and time criteria. An acute episode is a time period in which the symptom criteria are fulfilled. Or the first episode, currently in partial remission. So partial remission is defined as a period of time during which an improvement after a previous episode is maintained and in which the defining criteria of the disorder are only partially fulfilled. First episode, currently in full remission. So what's full remission? A period of time after a previous episode during which no disorder-specific symptoms are present. Multiple episodes, so more than one, currently in the acute episode. Multiple episodes currently in partial remission, multiple episodes currently in full remission, or continuous. The symptoms remain for the majority of the disorders. Unspecified, so they don't fit any of that criteria. With catatonia, which we talked about before, and then the current severity level. Now, I don't want you to feel overwhelmed by this information. It is a lot of information. But as an LMHC, my guess is you will probably never be diagnosing schizophrenia. Definitely not on your own. It's definitely a team approach. Doctors are involved, hospitals are involved, families are involved. The patient's history is long, and that's involved too. So for schizophrenia, we're just going to concentrate on learning about the information, having an awareness of the information, learning about what the symptoms look like, and how you can work as a team to support patients with schizophrenia. So don't be freaked out by all the information, because we'll talk about it. So, epidemiology of schizophrenia, the prevalence. Schizophrenia affects slightly more males than females. It occurs in all ethnic groups around the world. So I found this statistic, which I thought was really interesting. This is from the National Institute of Mental Health. And if you ever want to look any of this up, the NIMH website is fantastic. It gives tons of information. So the prevalence, according to that database, is 1.1% of the population over 18. So it's small. It's kind of rare. But at any one time, as many as 51 million people worldwide suffer from schizophrenia. So that number feels really daunting next to 1.1% of the population. So I thought that this was cool that they broke it down by geographical area. So 6 to 12 million people in China, 4.3 to 8.7 million people in India. So those are both rough estimates based on the population. 2.2 million people in the United States. 285,000 people in Australia, over 280 people in Canada, and over 250,000 diagnosed cases in Britain. So big differences in the number there, but I thought that was pretty interesting to share. Symptoms such as hallucinations and delusions usually start between the ages of 16 to 30. Males tend to experience symptoms a little earlier than females. Most commonly, schizophrenia occurs in late adolescence and early adulthood. It is uncommon to be diagnosed with schizophrenia after age 45. So those of us that are suffering with an anxiety disorder, once you are over the age of 45, you don't have to worry about schizophrenia. That's a joke. Schizophrenia rarely occurs in children, but awareness of childhood onset schizophrenia is definitely increasing. It can be difficult to diagnose schizophrenia in teens. This is because the first signs can include a change of friends, a drop in grades, sleep problems, and irritability. So all those behaviors that are, first of all, totally common about, in teenagers, but also look like other things, look like depression, look like ADHD, look like anxiety, look like substance abuse. A combination of factors can predict schizophrenia in up to 80% of youth who are at high risk of developing the illness. These factors include isolating oneself and withdrawing from others, an increase in unusual thoughts and suspicions, and a family history of psychosis. This pre-psychosis stage of this disorder is called the prodromal period. So let's see. Peak age of onset for the first psychiatric episode, like we said, early to mid-20s for males, late 20s for females. Slow and gradual development of symptoms. That's really important. You're not going to wake up tomorrow and have full-blown schizophrenia. Your symptoms are going to develop slowly. Your thoughts are going to start to develop, that thought content is going to start to develop slowly. Risk factors, so genes in the environment and brain chemistry and structure. There is a lot of research around the risk factors of schizophrenia and what causes schizophrenia. So when we look at genes in the environment, scientists have long known that schizophrenia sometimes runs in families. The illness occurs in less than 1% of the general population, but it occurs in 10% of people who have a first-degree relative with a disorder, such as a parent, a brother, or a sister. People who have second-degree relatives, so aunts, uncles, grandparents, or cousins with the disease, also develop schizophrenia more often than the general population, so it runs in families. The risk is highest for an identical twin of a person with schizophrenia. He or she has a 40 to 65% chance of developing the disorder. Although these genetic relationships are strong, there are many people who have schizophrenia who don't have a family member with a disorder, and conversely, many people with one or more family members with a disorder who do not develop it themselves. Scientists believe that many different genes contribute to an increased risk of schizophrenia, but that no single gene causes the disorder by itself. In fact, recent research has found that people with schizophrenia tend to have higher rates of rare genetic mutations. These genetic differences involve hundreds of different genes and probably disrupt brain development in diverse and subtle ways. Research into various genes that are related to schizophrenia is ongoing, so it is not yet possible to use genetic information to predict who will develop the disease. Despite this, tests that scan a person's genes can be bought without a prescription or a health professional's advice. Ads for the test suggest that with a saliva sample, a company can determine if a client is at risk for developing specific diseases, including schizophrenia. However, scientists don't yet know all of the gene variations that contribute to schizophrenia, and those that are known raise the risk only by a very small amount. Therefore, these genome scans, which they're called, are unlikely to provide a complete picture of a person's risk for developing a mental disorder like schizophrenia. In addition, it certainly takes more than genes to cause the disorder. So there's this interaction of genes in the environment again. So this interaction are necessary for schizophrenia to develop. Many environmental factors may be involved, such as exposure to viruses or malnutrition before birth, problems during birth, and other not yet known psychosocial factors. Scientists believe that many different genes may increase the risk of schizophrenia, but that no single gene causes the disorder by itself. It is not yet possible to use genetic information to predict who will develop schizophrenia. Scientists also think that interactions between genes and aspects of the individual's environment are necessary for schizophrenia to develop. So these environmental factors may involve exposure to viruses, malnutrition before birth, problems during birth, and psychosocial factors, which I think I already said once. The second risk factor I want to talk about is brain chemistry and structure. So scientists think that an imbalance in the complex interrelated chemical reactions of the brain involving the neurotransmitters dopamine and glutamate and possibly others plays a role in schizophrenia. Neurotransmitters are substances that the brain cells use to communicate with each other. Scientists are learning more about how brain chemistry is related to schizophrenia. Also, the brain structures of some people with schizophrenia are slightly different than those of healthy people. For example, fluid-filled cavities at the center of the brain, called ventricles, are larger in some people with schizophrenia. The brains of people with the illness also tend to have less gray matter, and some areas of the brain may have less or more activity. These differences are observed when brain scans from a group of people with schizophrenia are compared with those from a group of people without schizophrenia. However, the differences are not large enough to identify individuals with the disorder and are not currently used to diagnose schizophrenia. Studies of brain tissue after death have also revealed differences in the brains of people with schizophrenia. Scientists have found small changes in the location or structure of brain cells that are formed before birth. Some experts think problems during brain development before birth may lead to faulty connections. The problem may not show up in a person until puberty. The brain undergoes major changes during puberty, and these changes could trigger psychotic symptoms in people who are vulnerable due to genetics or brain differences. Scientists have learned a lot about schizophrenia, but more research is needed to help explain how it develops. So there are clinical trials all over the place. Like I said, if you go to that NIMH website, you can get tons of information, and I'll show it in class too, around trials and research. And scientists are working really hard to figure out where schizophrenia comes from, what causes it, so we can put preventative programs in place. So treatment for schizophrenia. Like I said before, you're not going to be treating, as an LMHC, you're not going to be treating a patient or a client that has schizophrenia by yourself. It's definitely going to be a team event, and it's something that you're going to get a lot of support around, and you're going to use a lot of people in your network around. But I definitely wanted to go over some of the treatments for schizophrenia. So, first line of treatments, antipsychotics. Antipsychotic medications are usually taken daily in pill or liquid form. Some antipsychotics are injections that are given once or twice a month. Some people have side effects when they start taking medications, but most side effects go away after a few days. Doctors and patients can work together to find the best medication or medication combination and the right dose. So if you are interested in looking at dosages of antipsychotics for for individuals with schizophrenia, you can check out the U.S. Food and Drug Administration website, which is www.fda.gov. And that gives you lots of information on dosages and warnings and patients and all stuff that you need to know, because if a client comes in to you and says, oh, I'm experiencing this symptom since I changed this medication, it's important for you to know that information in order to be able to consult with the client's doctor. Psychosocial treatments, this is where you come. This is your neck of the woods, I guess. So psychosocial treatments can help people with schizophrenia who are already stabilized. Psychosocial treatments help individuals deal with the everyday challenges of their illness, such as difficulty with communication, work, and forming and keeping relationships. So lots of psychoed going on with patients with schizophrenia and with their families and with the people in their lives. Learning and using coping skills to address problems helps people with schizophrenia to pursue their life goals such as attending school or work. And individuals who participate in regular psychosocial treatment are less likely to have relapse or be hospitalized. So that's really important. Therapy really, really, really helps clients with schizophrenia, and my guess is that it really helps their families as well. Coordinated specialty care. So this treatment model integrates medication, psychosocial therapies, case management, family involvement, and supported education and employment services, all aimed at reducing the symptoms of schizophrenia and improving quality of life. So this is like the whole package. The coordinated specialty care would be you working with a case manager, working with a family, working with a doctor, working with employment services and educational services. So this is kind of everybody coming together to help the client. Let's see, there is a National Institute of Mental Health, so that NIMH research project called Recovery After an Initial Schizophrenia Episode, and we'll look at that in class. But it's a project that seeks to fundamentally change the trajectory and prognosis of schizophrenia through coordinated specialty care treatment in the earliest stages of the disorder. So the acronym for the program is RAISE. It's designed to reduce the likelihood of long-term disability that people with schizophrenia often experience and help them lead productive, independent lives. So if this is an area that is of interest to you, it's definitely a very specialized area. You need a lot of training around schizophrenia, but so interesting, and so much to do in the field around research and working with families and improving quality of life, and it's just very interesting area of psychopathology. So illness management skills. People with schizophrenia can take an active role in managing their own illness. Once they learn basic facts about schizophrenia and its treatment, they can make informed decisions about their care. If they know how to watch for the early warning signs of relapse and make a plan to respond, patients can learn to prevent relapses. Patients can also use coping skills to deal with persistent symptoms. So you, as an LMHC, would definitely help with illness management skills. Again, very specialized, though. You need a lot of training around how to do that. And then rehabilitation. So rehabilitation emphasizes social and vocational training to help people with schizophrenia participate fully in their communities. Because schizophrenia usually develops during their critical career development years from 18 to 35, right where your career is starting, the career and life trajectories for individuals with schizophrenia are usually interrupted, and they need to learn new skills to get their work life back on track. Rehabilitation programs can include employment services, money management counseling, and skills training to maintain positive relationships. So this is where a rehabilitation counselor would come in handy to work with you around this kind of stuff. Like I said, family education and support. So lots of psychoeducation, teaching relatives or interested individuals about schizophrenia and its treatment, and it strengthens, these loved ones' capacity to aid in the client's recovery. CBT, always CBT. We know what CBT is, so we can skip the talk about that. And then self-help groups. So self-help groups for people with schizophrenia, group members support and comfort each other and share information and helpful coping strategies. Professional therapists are usually not involved with self-help groups. So this is a place where you could give a referral to your client. People in self-help groups know that others are facing the same problems, which can help everyone feel less isolated and more connected. So you could offer a referral to a self-help group for the client, him or herself, that has symptoms of schizophrenia, or for their family members as well. So the rest of the slideshow I put in a separate file just because it takes too long to upload. So go ahead and watch the next slideshow now.